Hi class, Dr. Fife here, and I want to go over the pulmonary system, and we're going to first start with the structure and function of the pulmonary system. Let's just do a little structural overview. We have the upper airways, 2 lungs, lower airways, blood vessels, chest wall, and diaphragm. The left and right main bronchi enter the lungs at the hyla, and they're the roots of the lungs. There's epithelial lining of the bronchi. This contains single-celled exocrine glands, the mucus-secreting goblet cells. The lobes of the lungs, there's 3 in the right lung and 2 on the left. Conduction airways, we have the upper airways of the nasopharynx, oropharynx, and related structures. The larynx connects the upper to lower airways, and the trachea connects the larynx to bronchi. This divides the bronchi at the carina, and the carina is an area that is sensitive and can cause cough and airway narrowing when stimulated. The left bronchus branches at a 45-degree angle. The right is larger and more vertical. So aspirated food and liquids have a tendency to affect the right lung more than the left. The gas exchange airways, the bronchioles terminate in gas exchange airways. Oxygen enters the blood and carbon dioxide is removed. The respiratory bronchioles, alveolar ducts, and alveoli, together these are called the acinus, and these all participate in gas exchange. Now the alveolar are primary gas exchange units of the lungs. There's 2 types of epithelial cells here. Type 1, alveolar cells that provide structure, and type 2 secrete surfactant, which prevent the lung from collapsing. Alveolar contains cellular components of inflammation and immunity, particularly mononuclear phagocytes or alveolar macrophages, and these ingest foreign material. Pulmonary and bronchial circulation. Pulmonary circulation facilitates gas exchange, delivers nutrients to the tissues, acts as a reservoir for the left ventricle, and serves as a filter system to remove clots, air, and other debris. The pulmonary artery, this follows the branching bronchi and carries deoxygenated blood from the heart to the lungs. Pulmonary veins, which are dispersed randomly throughout the lungs, this carry oxygenated blood from the lungs to the heart. And the veins in the pulmonary system don't have valves like those in the circulatory system. More of pulmonary bronchial circulation. This is just a repeat of information here in that top one. Pulmonary circulation has lower pressure and resistance to systemic circulation, resistance than systemic circulation. Again, the alveolar capillary membrane is where gas exchange occurs. The pulmonary lymphatic capillaries drain the membrane that surrounds the lungs. The lymphatic system plays an important role in keeping the lungs free of fluid and provides for immune defense. Control of pulmonary circulation, the contraction and relaxation occur in response to local humoral conditions. Most important cause of pulmonary artery constriction is low alveolar partial pressure of oxygen, or PaO2. The chest wall, which is made up of the skin, ribs, and intercostal muscles, these protect the lung from injury, and its muscles in conjunction with the diaphragm perform the muscular work of breathing. Pleura is a serous membrane that adheres firmly to the lungs, and the membrane covering the lungs, the parietal pleura, lines the thoracic cavity. And the area between the 2 pleura is the pleural space or cavity. Ventilation, this is the mechanical movement of gas or air into and out of the lungs. Your respiratory rate is actually your ventilatory rate, and it's the number of times gas is inspired and expired every minute. Breathing is involuntary because homeostatic changes in the ventilatory rate and volume are adjusted automatically by the nervous system to maintain normal gas exchange. The respiratory center, this is in the brainstem, and it controls respiration by transmitting impulses to the respiratory muscles, causing them to contract and relax. Ventilation is calculated by multiplying ventilatory rate or breaths per minute by the volume of air per breath, liters per breath or tidal volume. And this is minute volume and is expressed in liters per minute. Alveolar ventilation cannot be accurately determined by ventilatory rate, pattern, or effort. You need to get an arterial blood gas to measure that. The lung has receptors, irritant receptors, stretch receptors, and J receptors. The lungs are innervated by the autonomic nervous system, and the parasympathetic and sympathetic divisions of the ANS control airway caliber by stimulating bronchial smooth muscles to relax. The parasympathetic causes smooth muscle to contract, and sympathetic causes it to relax. Chemoreceptors monitor pH, PaCO2, and PaO2. Central chemoreceptors monitor arterial blood indirectly by sensing changes in pH in the cerebrospinal fluid. Peripheral chemoreceptors, which are located in the aortic bodies, aortic arch, and carotid bodies, these are primarily sensitive to oxygen levels, and they increase ventilation in response to arterial hypoxemia. Okay, more on the respiratory center. This is located in the brainstem. Controls respiration by transmitting impulses to the respiratory muscles, which causes them to contract and relax. It's composed of groups of neurons. We have DRG, VRG, pneumotaxic center, and apneustic center. DRG sets the basic automatic rhythm of respiration. DRG receives afferent impulses from peripheral chemoreceptors in carotid and aortic bodies, which detect PaCO2 and PaO2. VRG, this is in the medulla, and this contains inspiratory and expiratory neurons, and it becomes active when increased ventilatory effort is required. Pneumotaxic and apneustic centers are situated in the pons. These do not generate primary rhythm, but act as modifiers of inspiratory depth and rate, which is established by the medullary center. Again, lungs are innervated by the autonomic nervous system. Parasympathetic and sympathetic divisions control the airway caliber by stimulating bronchial smooth muscle to relax or contract. Parasympathetic is going to cause contraction or constriction, and sympathetic causes muscles to relax or dilate. Hypo and hyperventilation can occur. Hypoventilation, there is inadequate alveolar ventilation in relation to metabolic demands, caused by alterations in pulmonary mechanics or a neurologic control of breathing such that minute volume or tidal volume times respiratory rate is reduced. CO2 removal does not keep up with CO2 production, and PaCO2 increases, or the patient will have hypercapnia. And there's an increase in hydrogen ion in the blood or respiratory acidosis that can occur. Hyperventilation, this is where the alveolar ventilation exceeds the metabolic demands, and the lungs remove CO2 at a faster rate. This results in a decreased PaCO2, or also called hypocapnia. Respiratory alkalosis it can occur here, and it can interfere with tissue function. And you can do an arterial blood gas to determine if the patient is in respiratory alkalosis or acidosis. Mechanics of breathing, mechanical aspects of inspiration, expiration. We have the major and accessory muscles of inspiration and expiration, the elastic properties of the lungs and the chest wall, and the resistance to airflow through the conducting airways. The major muscles of inspiration are diaphragm and external intercostal muscles. Expiration is passive and requires no muscular effort. Alveolar ventilation is possible by surfactant, which lowers surface tension by coating the air liquid's interface in the alveoli. Elastic recoil, this is the tendency of the lungs to return to resting after inspiration, and this permits passive expiration. Bronchoconstriction, this increases airway resistance and can be caused by stimulation of parasympathetic receptors, irritants, or inflammatory mediators. Bronchodilation, this decreases resistance to airflow and is caused by beta-2 adrenergic receptor stimulation. The work of breathing is determined by muscular effort required for ventilation. Measurement of gas pressure. Partial pressure is the portion of total pressure exerted by an individual gas. Gas transport happens in 4 steps. Oxygen to the cells, there's ventilation of lungs, diffusion from alveoli to the capillary blood, perfusion of systemic capillaries with oxygenated blood, diffusion of oxygen from systemic capillaries into cells. CO2 out of cells, there's diffusion of CO2 from cells into systemic capillaries, perfusion of pulmonary capillary bed by venous blood, diffusion of CO2 into the alveoli, and removal of CO2 from the lung by ventilation. Test of pulmonary function, spirometry. This will measure the forced expiration and measures the volume and flow. Diffusing capacities, the rate of gas diffusion across alveolar capillary membrane. Arterial blood gas analysis can be done to look at the pH and gas concentrations. With acidosis, you'll see a low pH, alkalosis, a high pH. There's ventilatory alterations. Patient may have decreased PaO2. Chest X-ray, this can show air trapping in the alveoli and airways, consolidation of lung tissues, and any nodules that may be there. Okay, so we'll look at some alterations of pulmonary function. And so think about what clinical manifestations would you expect to see in a patient with pulmonary disease? And then we'll go over some of these. Most commonly, you're going to see patients complaining of dyspnea and cough. These are the 2 most common pulmonary complaints. Dyspnea is a subjective experience of breathing discomfort, and the severity of the experience of dyspnea may not directly correlate with the severity of underlying disease. Patient may have dyspnea on exertion when they're getting up and moving around, or they may have orthopnea where they're short of breath when they're laying down, laying flat. Patient may complain of cough. Now, a cough is a protective reflex. It's important to know if it's acute or chronic. An acute cough lasts about 2 to 3 weeks, and a chronic cough is more than 3 weeks, but some believe that it's 7 to 8 weeks is a more appropriate time frame to consider a chronic cough. Patient may have abnormal sputum. There can be changes in the amount, consistency, color, and odor of sputum. Patient may have hemoptysis. Maybe abnormal breathing patterns. Normal ventilatory rate is 8 to 16 breaths per minute. Tidal volume 400 to 800 milliliters. Patient may have too small respirations, which can be caused by strenuous exercise or metabolic acidosis, or Cheyne-Stokes breathing, where there are alternating periods of deep and shallow breathing. There's some other types of breathing patterns here for you to go over and review. Again, hypo and hyperventilation. Hypoventilation is the inadequate ventilation in relation to metabolic demands. Alterations in pulmonary mechanism or in the neurologic control of breathing. Tidal volume and respiratory rate is reduced. Hyperventilation, there's alveolar ventilation that exceeds metabolic demands. The lungs remove CO2 at a faster rate than it is produced by cellular metabolism. Common pulmonary issues, the patient may have clubbing. This is a bulbous enlargement of the end of the digit, and it's associated with diseases that interfere with oxygenation. A friend of mine, his husband had cystic fibrosis, and he had pretty pronounced clubbing on his fingers. The patient may have pain. They can have pleural pain that is sharp or stabbing. This can be caused by infection or inflammation. Pulmonary pain, central chest pain that is pronounced after coughing, and this again too can be caused by infection or inflammation. Patient may have pain in the chest wall, muscle or rib pain. Rib fractures or excessive coughing can cause this. There can be inflammation of the costochondral junction, and pain may be reproduced by pressing on the sternum or ribs, but the patient may not like you very much when you're doing that. All right, so let's talk about some lung cancers. One category is the non-small cell carcinoma. One type of that is the squamous cell carcinoma. This accounts for 30% of bronchogenic carcinomas, and smokers with COPD have a higher incidence of this type of tumor. These are generally centrally located near the hyla and project into the bronchi. Patient may have non-productive cough or may have hemoptysis. Pneumonia and atelectasis are often associated with squamous cell carcinoma. Chest pain is a late symptom associated with large tumors. And metastasis tends to happen late in disease with this type of cancer. Okay, another type of non-small cell carcinoma, we have the adenocarcinoma. This is a tumor arising from the glands. 35 to 40% of bronchogenic carcinomas are adenocarcinoma. This occurs more in females, non-smokers, and Asians. Risk factors include environmental secondhand smoke, such as somebody living with a smoker or around a smoker all the time. Occupational carcinogens, coal, dust, different things people may come in contact to in the workplace, viruses, hormones, and a positive family history. Patients may be asymptomatic, and this may be found on a routine chest X-ray. Large cell carcinoma, 10 to 15% of bronchogenic carcinomas are this type. Cells lost all evidence of differentiation and is commonly referred to as undifferentiated large cell aplastic cancer. Tumors commonly arise peripherally, but are found centrally and can grow to distort the trachea and cause widening of the carina. Neuroendocrine lung tumors, the small cell or oat cell carcinoma. This is the most common type of neuroendocrine lung tumor, accounts for about 14% of bronchogenic carcinomas. And this does account for about 25% of lung cancer deaths. Most tumors arise from the central part of the lung. And this type of cancer has the strongest correlation with tobacco smoking. These tumors have a rapid growth and they tend to metastasize early and widely. And these do have the worst prognosis of all the different types of lung cancers. Okay, so we're going to look at some restrictive lung disorders and some obstructive pulmonary disorders. Restrictive lung disorders, there can be decreased compliance of lung tissue happening with this restrictive lung disorder. Takes more effort to expand the lungs during inspiration, which increases the work of breathing. Examples of this include aspiration, or there's fluid or solid particles in the lungs, atelectasis, which is the collapse of lung tissue, bronchiectasis, there's persistent abnormal dilation of the bronchi, and this occurs with respiratory conditions associated with chronic bronchial inflammation and associated with systemic disorders such as rheumatoid disease, irritable bowel disease, or AIDS. Clinical manifestations, patient may have a chronic productive cough, recurrent lower respiratory tract infections, and voluminous amounts of foul-smelling purulent sputum, which does not sound fun. Clubbing and hemoptysis can also occur. Other restrictive lung disorders, pulmonary fibrosis, there's excessive amounts of fibrous or connective tissue, pulmonary edema or excess water in the lungs, and acute lung injury or acute respiratory distress syndrome, abbreviated ARDS, which is a spectrum of acute lung inflammation and diffuse alveolar capillary injury. Obstructive pulmonary diseases, examples are asthma, COPD, respiratory tract infections, and pulmonary vascular disease. And I'm going to cover here a little bit more on asthma and COPD, but please make sure you're reviewing the information on these other obstructive pulmonary diseases in the textbook. Okay, asthma, chronic inflammatory disorder of the bronchial mucosa, causes bronchial hyperresponsiveness, constriction of airways, and variable airflow obstruction that is reversible. This is commonly a familial disorder. There's over 100 genes identified with asthma. Genes in particular that are involved with asthma are the genes that influence the production of interleukin 4, 5, and 13, IgE, eosinophils, mast cells, adrenergic receptors, leukotrienes, nitric oxide, and transmembrane proteins of endoplasmic reticulum. Clinical manifestations: the patient is asymptomatic between attacks and the PFT is normal. Partial remission: the PFT may still be abnormal. And when a patient has an exacerbation, they can have chest constriction, expiratory wheezes, dyspnea, non-productive cough, prolonged expiration, tachycardia, and tachypnea. There's a serious life-threatening condition called status asthmaticus, where the patient goes into respiratory distress or respiratory acidosis, and this is can be life-threatening. And the picture here just showing the differences in the airway. You can see the one with asthma and how restricted that is. Excuse me, obstructive that is. COPD, this is a preventable and treatable disease with some extrapulmonary effects that may contribute to the severity in individual patients. Airflow limitation is not fully reversible. This is the third leading cause of death in the US. Think about what some of the risk factors for COPD are, and we're going to go on this on the next slide. Chronic bronchitis: there's hypersecretion of mucus and chronic productive cough, where the patient may have emphysema, where there's abnormal permanent enlargement of gas exchange airways. It's accompanied by destruction of alveolar walls without obvious fibrosis. Patient may have more chronic bronchitis or more emphysema, one or the other, or may have a mix of the both. COPD risk factors: tobacco smoke, very big risk factor. This can be cigarette, pipe, or cigar, or can be secondhand smoke. Occupational dust and chemicals, indoor and outdoor air pollution, factors that affect lung growth during gestation and childhood, such as low birth weight or recurrent respiratory infections. And there are genetic susceptibilities. There's the alpha-1 antitrypsin gene, and this can lead to patients having emphysema at an early age or in non-smokers. Clinical manifestations: chronic bronchitis, decreased exercise tolerance. Patient may have wheezing and shortness of breath and may have a productive cough. With emphysema, there's dyspnea on exertion, which later progresses to marked dyspnea even at rest. There's little cough and very little sputum. And the image here, we have the blue bloaters and the pink puffers, just showing the different manifestations that you can see with patients with chronic bronchitis and those with emphysema. Okay, so let's look at some alterations of pulmonary function in children. Upper airway: all conducting airways are present at birth and change only in size during childhood. The branching of the bronchial tree is complete by the 16th week of fetal life. The small diameter of airways can lead to obstruction. It's important to note that infants are obligatory nose breathers and they're unable to breathe through their mouth. So nasal congestion is a serious issue, and that's why moms are always having to suction out the baby's nostrils. Lower airways and lung parenchyma: there's surfactant, which is a lipid protein mix that is produced by those type 2 alveolar cells. And this is critical for maintaining alveolar expansion, thus allowing normal gas exchange to occur. Chest wall dynamics: the chest wall compliance is high in infants. The cartilaginous structures of the thoracic cage are not yet well ossified, and the chest wall is easily collapsible. Metabolic characteristics: there's greater basal metabolic rate than that of the adult, and oxygen consumption is greater per unit of body weight. The work of breathing increases VO2 exponentially with respiratory distress. There's immunologic incompetence. Babies do get passive immunity with IgG that's conveyed through the placenta from the mom to the baby. And breastfeeding allows for the transfer of IgA, IgM, and IgG after birth. Physiologic control of respiration: Newborns have blunted ventilatory response to hypoxia, and exposure to maternal smoking has deleterious effects on lung development. Very important to encourage moms to not smoke. Disorders of the upper airways, there's upper airway obstruction. This is a crucial issue in upper respiratory, its patency. Acute onset of upper airway obstruction can be caused by infections, foreign body aspiration, angioedema, obstructive sleep apnea, and trauma. Chronic upper airway obstruction has many etiologies, including congenital malformations, cartilaginous weakness, vocal cord paralysis, and subglottic stenosis. Common sign of upper airway obstruction is stridor, which is a harsh vibratory sound of variable pitch, and this is caused by a turbulent flow through partially obstructed airways. Infections, croup, there's two different categories. There's acute laryngotracheal bronchitis and spasmodic croup. Diphtheria is associated with croup. It can have a viral etiology caused by influenza A, RSV, or the respiratory syncytial virus, rhinovirus, adenovirus, and rubella. Spasmodic croup, this is characterized by hoarseness. Patient may have a barking cough or stridor. This usually has a sudden onset, usually at night and without a viral syndrome. This is associated with viruses, allergies, asthma, and gastroesophageal reflux disease in kids. Clinical manifestations, rhinorrhea, sore throat, low-grade fever, that harsh seal-like barking cough, hoarse voice, and inspiratory stridor. Acute epiglottitis, the incidence is decreasing of this due to the Hib immunization, the H influenza immunization. There are some cases that are due to Hib vaccine failure or alternative pathogens such as streptococci, candida, staph aureus, or viral pathogens. Clinical manifestations, patient may have high fever, irritability, sore throat, inspiratory stridor, severe respiratory distress, and they may sit in like a tripod position and have drooling and dysphagia. Tonsillar infection, this can be occasionally severe enough to cause an upper airway obstruction. Group A beta hemolytic streptococci and MRSA incidence has rose in the past 15 years. There's significant swelling of the tonsils and the pharynx, and the patient may develop a peritonsillar abscess, which is a complication to tonsillitis. Bacterial tracheitis, this is the most common potentially life-threatening upper airway infection, usually caused by staph aureus, MRSA, H influenza, streptococcus, or moraxella. Treatment of viral croup with corticosteroids has increased the risk for serious bacterial tracheitis. There's increased morbidity, possibly due to respiratory and cardiopulmonary arrest, respiratory failure, pneumonia, septic shock, toxic shock syndrome, ARDS, and MODS. Restrictive lung disorders, bronchiolitis. This is diffuse inflammation of the small airways or bronchioles. This can occur in adults with chronic bronchitis or with an upper or lower respiratory infection or with exposure to toxic gases. In children, this is most common, and it's most common in children younger than 2 years of age. The most common pathogen is RSV, or the respiratory syncytial virus, but it may also be associated with adenovirus. Older kids may get it from rhinovirus, influenza, parainfluenza, and the human metapneumovirus can also be involved there. This has a peak incidence in the winter and is a major cause of hospitalization in children younger than 1 year of age. Lower socioeconomic status is a risk factor. Healthy infants usually fully recover. Clinical manifestations that can be seen, rhinorrhea, cough, decreased appetite, lethargy, and fever. Patient may have tachypnea, expiratory wheezes, cough, mild fever, and varying degrees of respiratory distress. On auscultation, we may hear some wheezing and crackles. This is on asthma. We already went over this with the adult one. That's just a repeat of the information there. Aspiration of foreign body. Babies, kids like to put things in their mouth and sometimes ends up in the lungs. Most children who aspirate foreign body are between 1 and 3 years of age. At the time of aspiration, the patient may have coughing, choking, gag, wheeze, stridor, or cyanosis. There can be a quiescent period that can be from minutes to weeks or months. Symptoms reappear from irritation, granulation may develop around that foreign body, bronchial obstruction or infection may occur. Foreign bodies in the upper trachea typically produce inspiratory stridor, and those in the lower intrathoracic airways produce wheezing. And we can remove the foreign body with bronchoscopy. That's all I'm going to cover on these chapters. Please be sure you are reviewing the chapters in their entirety, as students are responsible for the entire chapter of information. Please let me know if you have any questions. Thank you all for your time. Have a great day.